for about 10 years now.
Probably 10 years now.
We've been using the arch table at our center for 10 years.
What I really like about the arch is the objective information that we get based on leg position. So we can actually call out numbers during the case and have consistent reproducible position of the leg throughout the surgery. What I really like is the metered traction that you can see. So you can be very consistent in how much soft tissue tension you're putting on to make sure you're not putting on too much or too little as you're going through the reduction process and the evaluation of stability. But really it's the overall reproducibility and objective information that we get from the arch table that I think separates it from the other options. I think the arch is very easy for myself and the staff to use. We're doing 2 rooms, and as we bounce back and forth between knees and hips, the staff is able to set up the table very easily in the hip room. They're able to get the patient positioned. I just have to walk in and sort of fine tune the positioning. And then the staff is very comfortable running the table and responding to the positions that I want, using those objective numbers for external rotation, abduction, how far we're dropping the leg, how much traction we're putting on the leg when that time occurs. I think we get excellent femoral exposure with the arch table. We've been able to calculate and sort of meter our delivery of the leg as we drop the leg down, so we can do a measured release and release just the tissues that are holding us back, so we can get excellent exposure. We've even been able to do restoration modular revision cases through the anterior approach using the arch table with little difficulty. So my technique and how I find that the arch table is helpful for that is we can start with our releases with the leg horizontal and then actually sort of meter the drop down. So we'll go down 2 clicks, see what tissue is under tension and needs to be released, drop another 2 clicks, figure out which soft tissue is holding us back, which area of the capsule needs to be released, and then drop it 2 more clicks before we go ahead and swing over into adduction. I think that allows us to really control our releases and really see what's holding us back without having to try to drop the leg fully initially and then kind of fight through a lot of different soft tissue and tension. I think it makes it a little bit safer, so you're not putting so much pressure on the trochanter with a big initial drop without those releases being performed. It really allows you to see which tissue you want to use, especially that initial 2-click drop sort of puts the abductors posterior a little bit, brings the proximal femur forward. And so you can really identify the difference between the capsule and the abductors and know which tissue you're releasing. And so you can be safe and confident that you're releasing the capsule and not the abductors. I don't routinely use another table for DA hips. I have some experience in labs in different places around the country where I've had some exposure to some of the different tables. I've found that the arch table is still superior to the other options at a much more affordable entry price for surgery centers or hospitals to look into.
Personally, I use robotic assisted surgery. So there's a method of measuring your preoperative offset and leg length and your postoperative. Because the way the arch table is designed, you can lock it into 0 degrees of rotation, 0 degrees of flexion or extension, and you can manually you can actually objectively measure the level of traction that you have on the limb. You can return it to that same position after you've done your surgery to determine postoperative range of motion and offset, which the other tables that I've used don't have that. They have a universal joint and you may be abducted 10 degrees, although it may look the same to the table operator as it did earlier on. I don't think there's any technique changes. I think the biggest difference, as I mentioned earlier, to tell you the truth, is that when I want to know what position the leg is in, it's much easier to reproduce that on the arch table than it is on the HANA table. There's no indicators on the HANA table that, for instance, tell you how much flexion or extension you have. You're relying on the ability and the eyes of the table operator to tell you that it's parallel to the floor. And similarly, whether or not the leg is abducted or adducted, again, you're relying on the table operator. The other thing that I think is easier on the arch table than the HANA table is that the length of the arm is shorter on the arch table than it is on the HANA table. So sometimes the HANA table, you have to drop the leg all the way to the floor, but the foot's not at the floor yet because the extension that goes as part of the table beyond where the foot is attached has touched the floor. Whereas and that requires you then to raise the table up, which may take it out of your operative field. I never have to raise or lower the table once I've got everything set on the arch table. Absolutely. Absolutely. First of all, it's much smaller. It's much easier to manipulate and move around the room. So we bring our patients in, the arch table is in the corner, and then we wheel it into position. I think that it is much easier to direct your table operator how to put the leg into different positions during the procedure, because it's all indicated there and it's all marked there in terms of the numbers, and you can lock it into a position and so on. Like, for instance, after I've done my releases around the femur and I want to expose the femur, I will just tell my table operator to lower the foot 2 clicks on the arch. I don't have to say lower it halfway to the floor, lower it a quarter of the way to the floor. I know that if I've done my releases properly, by lowering it only 2 clicks, which is a very short distance, that I'm going to be able to adequately expose the femur and do my work on the femur. And if in lowering it 2 clicks, I can't expose the femur, then from my perspective, I need to do more releasing of the femur than having the individual operating the table lower it even further. So I think it's a very easy apparatus to use, and to have your circulating nurse or whoever it is in the room that's going to be operating the table use it.
I like the arch because of the reproducibility, to position the leg in the position that I want it in for different parts of the procedure. We actually trialed 3 different tables. We trialed the arch, we trialed the Hana, we trialed a float table. And after spending, did about 25 cases with each table. And then we sat down with our physician's assistants who were running the table and asked them what they thought. The reasons that we went with the arch table were that when we called out what positions we wanted the leg to go into, the PA or whoever is running the table, sometimes we have an assistant run it at one of the other centers, they can actually just listen to what we say from the point of view of the numbers, and they know exactly where to put the leg. Whereas we found with the Hana table, it's not marked off specifically as far as sort of clicks and rotations. And if you have a good assistant, they'll know what to do. But we found ourselves more of, when we're using the Hana, it was like, oh, like put it down. Yeah, can you just move it over a bit? Move it over a bit more. Okay, just twist it a little bit. And it often took a long time to get it in the position we wanted in to do the operation. When we use the arch, we would say, can you just drop it down 2 clicks, rotate it 20 degrees, we'll pop it out, rotate 120 degrees, drop the table down to the floor, and adduct it over 40 degrees. And the person running the table specifically knows those numbers, they're marked on the table, and they can just go to that. When they're there, if we're having a problem, we don't have to say go a little more. We can say go 10 degrees more, go 20 degrees more. And we just felt it was a little bit more accurate as far as us working with the person running the table when you're doing it with a table, rather than if you were doing it without a table, you've obviously got somebody in the OR. Instead of running a table, you've got someone running the leg and holding it and putting it, where it needs to be. So in our estimation of the time factor, we found that we saved time using the arch because our assistants found it easier to use the arch table than the Hana. You really don't need a hook. When we were using the Hana table, they showed us the hydraulic hook to bring the leg up. I found if you needed a hook, number one, you hadn't done your releases right, and number two, you're at risk of breaking something because you've got a hydraulic hook trying to force the bone into a position it doesn't want to go into. It should pop up there. One of the reasons it didn't pop up with the Hana is because you got the body sitting on that little triangular pad, and the pelvis tends to rotate. Whereas with the arch, you're on a regular OR table and it's sitting very square at the end. So when we drop the leg, the end of the table almost is a bit of a fulcrum to help pop that femur up and get a good look at it. The assistants that helped us were really in favor of using this table because it was easy for us to coach them as to where to put the leg. In fact, you can take somebody who's only done it once or twice, and with a little coaching, they can actually be pretty good at running the table.